Good morning. Today we are going to talk about rheumatic fever, which is a very old topic but very important topic for the MD as well as for the DM examination. So coming to the introduction, rheumatic fever is a connective tissue or collagen vascular disease which is expressed as inflammatory reaction which involves heart, joints, brain, caused by beta hemolytic streptococcus, that is gas pharyngeal infection after a latent period of nearly 3 weeks. Rheumatic heart disease follows rheumatic fever as a non-suppurative manifestation of group A beta hemolytic streptococcal pharyngitis. French physician has rightly said, Ernest Charles Lasix, he said that rheumatic fever leaks at the joints, it doesn't affect much to the joint but bites the heart. So coming to the history of the rheumatic fever, the earliest description of rheumatic fever are very recent only, except for one probable description in the Hippocratic era. Crowded and poor working conditions are associated with rheumatic fever. This is a well-known factor. Crowded condition was associated with outbreak in the military barracks in World War II, that we all know. Rheumatic fever was a puzzle. Each manifestation was described separately. It was not coordinated that all these things, arthritis, carditis, chorea, marginatum, or the same disease. They were considered separately, but it was in the 1700 they put it together. Finally, the diagnostic criteria was established by 1944 by the T. Duquette Jones, who is a very well known name, and all the Jones criteria is very important and very well known to all of us. A large number of studies follows, with the largest contribution coming from the Irvington House Sanatoria in New York. So if you come to the epidemiology, WHO estimates that this is a European Heart Journal 2002, that 1.5 million children with chronic rheumatic heart disease in the industrialized countries. This number goes to very high, around 30 million in developing countries like India. Overall, there are 25 to 40% of cardiovascular diseases in developing countries. In India, 30% of the all admission in the hospital of cardiac patient, 30% is because of the rheumatic heart disease. The prevalence, of course, in 1940 to 83, it was around 1.8 to 11 per thousand school children, which is now which has gone down. 95, it was 1.5 to 4 per thousand. Overall rheumatic fever incidence is 0.32 to 0.54 per thousand. Western countries, it has gone down 0.05 per thousand, and Kyrgyzstan, which is in the part of the Russia, 543 per 100,000. Incidence is highest here in this country. So prevalence is 0.2 to 1.5 1,000 for rheumatic heart disease and 0.007 to 0.2 1,000 for rheumatic fever. This is the problem in India, ICMR. Rheumatic heart disease 0.5 to per thousand in between the 5 to 15 years of age group. This was the Nagy study in 2019. Mortality rate due to rheumatic heart disease is between 1.5 to 3.3%. Again, the Nagy study. Incidence is 0.54 to per thousand. Younger age of onset of rheumatic heart disease in our countries. Juvenile rheumatic heart disease more severe. We know all that it is very rapidly progressive and causes chronic lesions. Commonest heart disease associated with pregnancy in our country and found to in our 1% of the pregnant women, especially coming with rheumatic MS, MR, etc. 1/3 of patients with possible first attack of rheumatic fever develop chronic valvular lesion. So hospital admission rate, if you see, it is between 25 to 45% for all cardiac patients considered in various studies. And this is again the prevalence in various parts. This is the prevalence and the trends. The prevalence seen per thousand of rheumatic heart disease from 1919 to 2007 in the various studies. Then the Jag Vigyan study again, it in various done in various cities. The average rate per thousand was 0.5 to up to 5, and in this study, Jag Vigyan study, it is between 0.2 to up to 1.2 per thousand population. So prevalence based on ICMR multi-centric center, if you see between 1972 and 75, it was very high, around 11 per thousand. It has gone down to around 5.6 in 1984-87 and 1.2 in 2007. There are 4 types of patterns seen in the disease. First one is the graph shows that the decline in the rheumatic fever incidence after the introduction of the antibiotics, which is in the seen in the industrialized countries. Then the second pattern, if you see, is continuous high number which is seen especially in some poor countries, and number 3, after the introduction of the good health care, there is a fall in the there is a fall in the and introduction of antibiotics, there is a fall in the incidence of the rheumatic fever, and in some countries it has gone up again, especially if you see these countries like Jeffrey, etc. So this is the prevalence of rheumatic heart disease in various parts of India. And if you see the global burden of the rheumatic heart disease, the yellow one shows that if you see the incidence is less, but it is in various parts still it is very high. So coming to the pathogenesis of the group A beta hemolytic streptococci, there are cell wall proteins, capsule, that is the made up of hyaluronic acid, M protein, which is very important, highly antigenic, a group A carbohydrate, protoplast membrane, lipoic acid, and then the extracellular enzymes like streptolysin, streptokinase, DNase, and NDS, erythrogenic toxin, protease, amylase, etc. So coming to the pathogenesis, it is the molecular mimicry. What does the molecular mimicry means? That the antibodies which are formed against the bacterial various specific part, it acts against the body's own part. It cross reacts with the body own system, and that is that is the molecular mimicry which causes the similar, because the structure is similar. So it is because of this, and mainly it is said that both humoral and cellular immunity is involved, but the more important is the cellular immunity. So autoantibodies against group A carbohydrate, N-acetyl beta glucosamine and laminin basement membrane in heart wall endothelium. T cell is a peripheral blood cross react. This is very important, T cell with streptococcal M protein and cardiac myosin, and then monoclonal antibodies. These all are causes of molecular mimicry. So coming to the various cycle, if you see there is a susceptible host which gets associated with environment factors, especially overcrowding, then the repeated group A beta hemolytic streptococcal infection, priming of the immune response, pre-MAGE precipitate event, and the first episode of acute rheumatic fever, then the repeated ongoing infections possibly driving the valvular inflammatory reaction, and which develops into the chronic rheumatic heart disease. The molecular mimicry between group A streptococcus antigen and the host tissue, which leads to excreted T-mediated immune response, and which are usually determined by some genetically determined host factors. So environment factor, susceptible host, as well as the genetic factors, all these play, and repeated infections, all these play important role in the pathogenesis of rheumatic heart disease. So coming to the pathogenesis, the gas, that is the group A hemolytic, is presented to the peripheral epithelium, then it is engulfed by them, and then it is presented to the beta cell and T cell, and which causes which cross reacts with the various parts of which forms the antibodies against the bacteria, but with that cross reacts with the tissues of the heart, brain, joints, and skin. So pathogenesis is coming to this. If you see the infiltrates in the T cell infiltrations is there in the cardiac tissues, and this causes the valvular diseases, mainly valvular lesions, the mitral regurgitation, mitral stenosis, etc. So pathogenesis, again the streptococci hemolysis is the alpha beta non-hemolytic, and the very important is the protein M. M protein has more than 100 serotypes, and it is resistant to phagocytosis by the cells. So if you see, the cardiac valves are derived from the ventricular myocardium by a process of undermining. The valves are composed of a central core of connective tissue covered on both sides by endothelium. The central core of connective tissue is derived from the ventricular myocardium, and if you see the muscle and intermyocardial connective tissue, histopathologically indicates absence of myocardial and connective tissue damage in carditis due to acute rheumatic fever, but the immunohistopathology excludes myocardial damage in rheumatic fever. Hence, the site of damage in the valves derived from the ventricular myocardium has to be valve endothelium itself, and the endothelium, which consists of two parts, the endothelial cells and the basement membrane and interstitium. So these are the parts which are affected by the rheumatic involvement process, and where the pathogenesis lies, and not other parts. So it is well established that rheumatic fever follows gas infection of the tonsillopharynx and does not follow skin infection. Mesothelium and endothelium are derived from the mesenchymal cells. So mesothelial cell covers the tonsillopharyngeal region, whereas the because the ectodermal cells, which are completely different in composition from mesothelial cells which covers the skin, and probably because of that, after skin infection rheumatic fever does not occur. So various, as I already said, there is a various factors involved on the hyaluronic acid capsule, M protein, carbohydrate, protoplast membrane. The site of infection must be pharyngeal. Case report of skin infection of rheumatic fever is reported in Australia, but it is very, very rare. Nephrogenic strain does not cause rheumatic fever. Gas virulence, as I already said, M protein is the very important, and hyaluronic acid capsule. Both resist phagocytosis by the T cell and beta B cell. Antibody to M protein is type specific, and anticapsular immunity does not occur. So if you see the structure of the M protein, the N terminal contains two types of epitopes. Class 1 that is for the throat strain, and class 2 which is for the skin strain. Genes of M protein have been identified and arranged from 5 chromosomal patterns. By genetic analysis, rheumatogenic strain can be differentiated from the impetigo strain. Recently, genes of hyaluronic acid, streptolysin has also been identified. Following streptococcal sore throat, 1% of the school going children and nearly 3% in the military camps develop rheumatic fever. Incidence is 50% in patients with past history of rheumatic fever. So the chances of having recurrent infection is high with those who are already affected once. So 1/3 of the patient has no history of pharyngitis, which may be asymptomatic. Recent outbreaks has shown that 58% patient with the maybe have asymptomatic pharyngitis. Development and severity of rheumatic fever also depends a lot on host factors, as I already said. So attack rate following gas pharyngitis in individuals with a prior history of rheumatic fever is about 20-fold higher than for the general population. Increased susceptibility to recurrent attack may be attributed to priming of pathologic process in the first attack, or initial attack identifies individuals who are inherently susceptible to the complications of the gas. So the overcrowding is the most important environmental factor, directly proportional to persons per room. No effect of nutritional status of host, whether he is malnourished or not. 30 times more common in the poorer as children. Age and sex, usually younger age, sex, usually female more affected, does influence the clinical manifestation and presentation. Lifetime cumulative incidence of rheumatic fever in population exposed to rheumatogenic gas infection is 3 to 6% regardless of the geographic ethnicity. Family history of rheumatic fever, person have 5 times higher chances of developing rheumatic fever. Monozygotic twins has 6 times higher greater than the dizygotic twins of getting rheumatic fever. So heritability is also important in the rheumatic fever, and genetic factors is also important. Coming to the environment, incidence is falling consistently in industrialized countries, because we know that overcrowding is stopped and they are better having infrastructure, and then in the unemployment, lower socioeconomic status, distance from the healthcare center, health facility, school children of low socioeconomic class. These are all high risk factors for having rheumatic fever. So pathogenesis immunity can be B cell mediated. There is a proposed genetic susceptibility which can be transmitted autosomal recessive or autosomal dominant with limited penetrance, and then the blood secreted various DR markers. The agents, the untreated gas pharyngitis in rheumatic fever, streptococcal skin infections believed not to cause rheumatic fever, as I already said. Up to 3% of untreated epidemic gas pharyngitis develop rheumatic fever. So coming to the very important, the SCHOP bodies, two-hit hypothesis, antibody attack on wall endothelium, and that causes extravasation of T cell through activated epithelial cells into the wall tissue, leading to the formation of granulomatous nodules called SCHOP bodies, which is the pathogeny of rheumatic fever that is characteristic of rheumatic myocarditis. SCHOP bodies are of central necrosis, is surrounded by a ring of plump histiocytes called anti-SCHOP cells, discovered independently by Ludwig SCHOP and Paul Rudolph. So the jointly said SCHOP JPIL bodies. This is the structure of SCHOP bodies. You can say multinucleated gene cell with caterpillar nuclei. So rheumatogenic gas infection, susceptible host. So cycle is like that, which causes immunity reaction, which affects which damages the tissue and organ, and which causes the rheumatic fever. So as I already said, heart, joints, brains commonly involved. Degree of histological changes does not correlate with the severity of clinical findings. There is early exudative and degenerative phase, later proliferative and healing by fibrosis phase. S-sharp nodules not found in brain joints. Rheumatic fever follows an episode of gasopharyngitis after latent period of 2 to 3 weeks. During latent period, there is no laboratory or clinical parameters to see the active inflammation. One third of the patients develop rheumatic fever after asymptomatic infection. In outbreak, 50%, 58% have no symptoms. Most frequently children between the 4 to 15 years of age. In India and Saudi Arabia, even it is more younger, 3 to 5 years has been case reported. So clinical and epidemiological findings in diagnosis of gas is this history of fever, scarlet fever rash, headache, nausea, vomiting, abdominal pain, tonsillopharyngeal erythema, tonsillopharyngeal exudates, tender enlarged cervical nodes. All these are important. All these can be found, and features which suggest viral origin is the conjunctivitis, chorea, horse nuts, cough, diarrhea, etc. So the revised Jones criteria says that for patient with population with evidence of preceding gas infection, a patient is divided into two categories: patient with which has the high risk of the low risk population, and patient with the high moderate to high risk population. So in the first, usually two major manifestation or one major plus two minor manifestation, or diagnosis of for recurrent rheumatic fever, two major or one major and two minor or three minor only. So in low risk population, that is the population in which getting chances of is less than 2 per 100,000 school age children. So they are included are the carditis, then the subclinical or subclinical arthritis, that is it should be polyarthritis, then chorea, erythema marginatus, some subcutaneous nodules. But as far as the moderate to high risk, it is different is that the monoarthritis is also considered as a major factor. It is not necessary polyarthritis and the polyarthralgia also. Then the other minor features included are the polyarthralgia, fever, raised ESR, prolonged PR interval, etc., which is same. This is the global prevalence and mortality rate. Then if you see there is a changing profile of rheumatic fever. If you see in the present study that all the erythema marginatum, the five major factors, subcutaneous nodules, chorea, arthritis, carditis, their incidence is decreasing as compared to the previous study. It has gone dramatically down, maybe because clinically we are not that sound now. So clinical aspect in India, if you see the various studies, Padmavati, Rai, Sanya, Aurora, etc. Arthralgia is most common, around 45 to 50%. Then comes the arthritis, that can be 30 to in some study up to 60%. Carditis between 15 to 45%. Chorea around 5%. Subcutaneous nodules around 3%. Erythema marginatum is around 1.9%. Fever in all patients. So the evolution of the T-Zucker criteria for diagnosis of ARF and recurrence, it was started in 1951. It was minimized to the misdiagnosis and overdiagnosis. 1965 criteria were tightened by requiring supporting evidence of preceding streptococcal infection to prevent persistent overdiagnosis. In 1984, addressed overdiagnosis, cautioned against premature administration of salicylates and steroid, which was if not required. Also addressed usefulness of echo in differential diagnosis. For the first time it was introduced. 1992 revision expanded to new diagnostic tool, revision limited to criteria for initial attempt. If you see all these factors were included, but those which are excluded now are the abdominal pain, pericardial pain, epistaxis, pulmonary fighting, etc. Previous history of rheumatic infection with the JS is important. So diagnosis, first episode you requires two major or one major plus two minor plus supportive evidence of gas infection. Recurrence in a patient without established heart disease, same as above. For recurrence in a patient with established heart disease, two minor criteria and supportive evidence of previous gas infection is enough. For rheumatic chorea and insidious onset rheumatic carditis, that I will discuss later, no requirement for other major manifestation or supportive evidence of streptococcal sore throat is required. Indication of recurrence of rheumatic fever in an established case of rheumatic heart disease, appearance of the new murmur, change in the pre-existing murmur, pericardial rep, which has appeared in recent new onset, unexplained congestive heart failure, including cardiomegaly. So, various terminology: recurrence, a new episode of rheumatic fever following another infection occurring after 8 weeks following stopping treatment. So, rebound, manifestation of rheumatic fever occurring within 4-6 weeks of the stopping treatment or with tapering drugs. Relapse, worsening of rheumatic fever while under treatment and with carditis. Subclinical carditis, when clinical examination is normal but echocardiogram is abnormal, around 30% of patients having chorea present at subclinical carditis. Indolent carditis, here the persistent feature of CHF, murmur and cardiomegaly. There is no or very few features of carditis. Active or versus inactive rheumatic fever, this can be tested by inducing subcutaneous nodules, concentrated WBC of patient's own injected subcutaneously or oligoclonine process of one elbow and saline and another elbow just saline. So appearance of subcutaneous nodules in 5 to 10 days was accepted as indication of active rheumatic fever. Rheumatic fever does not cause myocarditis because there is an absence of increase in the cardiac biomarkers. Usually normal LV function radionuclide study do not indicate myocardial damage. Myocardial biopsy failed to identify presence of myocarditis, and Eschop nodules derived from mesenchymal cells, complete absence of cells of myocardial origin in the pathology, that is actin myosin desmin. So coming to the carditis, except carditis, none of its manifestations leave behind the significant residue. So carditis is the worst culprit. Endocardium, myocardium, pericardium involved in variable extent. Endocarditis causes valvular involvement, is the responsible for the unfavorable prognosis. Rheumatic carditis cannot be easily diagnosed in absence of valvular involvement. Carditis early manifestation, almost 80% of patients with carditis within first 2 weeks of onset of rheumatic fever. So what are the various features? Acute rheumatic carditis. First attack, there is a new onset murmur, apical systolic Kerry-Coombs murmur or AR murmur. Recurrence, change in murmur intensity or new onset murmur, invascent murmurs, and myocarditis, unexplained cardiomegaly, unexplained CHF or worsening cardiomegaly or worsening murmur. So acute rheumatic carditis, pericardial rep is present in the first attack. Recurrent attack also it can be there. Unexplained pericardial effusion, and you can see various miscellaneous findings like conduction disturbances. Most the endocarditis is most commonly involved are the mitral valve and aortic valve. Mitral valve is involved in 70 to 75% of patient. Aortic valve in 5 to 8% of patient. Mitral for aortic together around 20 to 25%. Tricuspid valve pathological is 30 to 50%, but clinical tricuspid valve involved is rare in first attack. Pulmonary valve is never recognized clinically and rare pathologically. So coming to the valvular apical pain systolic murmur, apical pain systolic mechanism is the active inflammatory valvularitis, valve prolapse, annular dysfunction, dilatation and ventricular enlargement. All these cause this apical pain systolic murmur. Characteristic long high pitched blowing pain systolic murmur. Site is usually apex and radiation to the axilla, grade 2 to 4. Does not change significantly with the position, and the differential diagnosis MVP, VSD, HOCM, congenital MR, etc. So, then again, coming to the murmur of AR, it is the basal diastolic murmur, left parasternal start after A2, high pitched blowing character. Isolated AR in the absence of mitral involvement is very unusual and very difficult to diagnose. Mechanism of is the cuspal inflammation, elongation, prolapse. Then the myocarditis is affected because of the soft S1, gallop sounds, cardiomegaly. Diagnosis can be done by chest X-ray and echo. CHF does not occur in the absence of hemodynamically significant MR, and LV function rapidly improves following mitral. So the myocardial LV dysfunction does not appear, but secondary to the valvular dysfunction, the LV dysfunction is seen, and it can be rapidly restored after the surgery. Pericarditis occurs in 6 to 15% during active stage. This you see the distant heart sound, friction rub, chest pain, large pericardial effusion, tamponade and constriction are very rare. Active pericarditis indicates active carditis. Underlying endocarditis must be present. Insidious or late onset carditis, it is very common in developing countries in young children. Acute rheumatic carditis for the first time with no or few other clinical symptoms or lab findings of rheumatic fever. Vague symptoms, that is very vague, like malaise, lethargy, poor appetite and vague ill health for a few weeks or months. Usually the mitral and aortic valve disease and CCF, ESR and CFP are elevated, but ASO is normal. Then coming to other manifestation with carditis, more prominent in younger patient, whereas arthritis is more common in older patient. Subcutaneous nodules, it is a late presentation but suggests usually underlying carditis. Erythema marginatum indicates underlying carditis. Chorea may or may not be associated with carditis. Differential diagnosis of carditis is infective endocarditis, which usually have positive blood culture, which has high spiking fever and associated with splenomegaly, clubbing, petechiae or embolic phenomena or microscopic hematuria. So prognosis of carditis depends upon the severity of the first attack. Mortality may be up to 1.3 to 1.3% in the first attack. Severe carditis is associated with pericardial effusion, cardiomegaly, CCF, severe regurgitation. Episode of rheumatic activity clinically lasts for 8 to 12 weeks in 95%, but in few patients it can last even longer. Coming to the arthritis, it is more common and more in severe in young adults than in teenager or children. 60 to 70% experience first attack, early in disease and frequently presenting complaint. Adolescent arthritis often is the sole manifestation, almost always migratory unless aborted by salicylates. Migratory joints involved sequentially, each completing independently and cycle of inflammation with resolution. Most of the time large joints are involved. Involvement of the small joints of the hands, feet, shoulder or hip are unusual. Never result in permanent joint deformity except Jacob's arthritis. Occurs in severe rheumatic heart disease, not in rheumatic fever. So joints are swollen, hot, painful, red and tender to touch, and there is a limitation of motion. Use untreated case arthritis lasts for 4 weeks. Dramatic response to salicylates, and if not, then diagnosis is doubtful. Synovial fluid is usually sterile. This is the diagram of arthritis of affecting elbow joint. This is the radial joint, and this is the Jacob's arthritis. Then arthritis in relation to other manifestation, polyarthritis and Sydenham chorea never occur simultaneously because chorea is a late manifestation. Carditis and arthritis do frequently coexist during bout of rheumatic fever, and when this occurs, there is an inverse relationship between severity of arthritis and carditis. Coming to a very important thing, post-streptococcal reactive arthritis, it is an unclear entity developed shortly after streptococcal infection. It is recurrent, severe and prolonged polyarthritis, symmetrical, and it is non-migratory in nature, not very responsive to salicylates, not clearly associated with other manifestation of rheumatic fever. Some patient may have silent or delayed onset carditis. Rheumatic prophylaxis should be given to these patients also. The chorea primarily occurs in the school children that between the 5 to 15 years, rarely after 20 years. Female preponderance is more common. Manifestation is the purposeless, involuntary, rapid movement of trunk or extremity, often associated with muscle weakness and emotional liability. Child usually fretful, irritable, inattentive at school, fidgety, severely disturbed. Physical incoordination, clumsiness, tendency to drop objects. All muscle group, hand, feet, face are affected. Face, there is a grimaces, grins, frown, speech jerky and staccato, tongue protracted and resemble bag of worms. There is a milkmaid drip, then the pronator sign, all this can be found. Relation to other manifestation usually occurs 6 to 8 weeks of case infection. Latent period may be up to 1 to 7 months when associated with carditis is usually clinically inapparent carditis. Last for 1 week to 2 years, but usually 8 to 15 weeks. Recurrence, it is major manifestation in one episode, it can occur again in the second episode. Then coming to the erythema marginatum, in India it is 0.2 to 2% of the people has been reported. Rare manifestation, distinctive invascent pink rash, often pale center surrounded by serpiginous margins, sizes varying, location is usually the trunk, proximal extremities, never on the face. It is a transient, migratory and induced by application of heat or more prominent after the hot shower, not pruritic. This is the picture. Then individual lesions may come and go in minutes to hours, at times changing shape before the observer's eye or coalesce with adjacent lesion to form varying pattern like smoke ring. Relation to other manifestation, it occurs early in the course, persist or recur for months or even after a year, continuing after manifestation of disease have subsided. No influence of anti-inflammatory treatment associated with carditis, but unlike subcutaneous nodules, no necessary severe carditis. Coming to the subcutaneous nodules are reported in 3 to 6% in Indian population. Firm painless nodules overlying the skin moves freely. Size 0.5 to 2 centimeter. Number 1 to few dozens, but usually 3 or 4. Duration is usually 1 to 2 weeks. Disappears within 8 to 12 weeks in most patients. Seldom more than 1 month. Usually site is the extensor surface of the elbow, knee, wrist, occipital region, etc. This is the picture. Subcutaneous is not pathognomic and it can occur in SLE, rheumatoid arthritis as well. Relation to other manifestations, most cases are associated with presence of carditis. Usually in severe carditis, it occurs in coughs. It usually appears after several weeks after onset of carditis. Then coming to the minor manifestation, arthritis, pain in one or more joints without objective evidence of inflammation, common in rheumatic recurrence and patient with RSD in developing countries. Acceptable to consider diagnosis of rheumatic fever in a patient with known case of RSD on basis of migratory polyarthritis. Not to be considered minor criteria when arthritis is present. Pain usually involves large joints. Fever usually early in the course, almost all rheumatic fever has some history of fever. Fever never lasts more than several weeks. In Korea, patients are afebrile. Then the various other symptoms: abdominal pain, tachycardia out of proportion to fever, sleeping tachycardia, malaise, anemia, epistaxis, and precordial pain. Then if you see the acute phase reactor, elevated ESR, CRP, that can be these findings can be altered by treatment with salicylates and steroids. Anemia and CSF can be seen. There is a prolonged PR intervals, which atropine can normalize PR interval. Movies type 1 and 2 block have also been reported, and sometimes CHB has also been reported. There is supportive evidence of antecedent gas. Diagnosis of rheumatic fever is unlikely when the lack of serological or microbiological evidence of streptococcal infection, except two exceptions, that is the chorea and indolent rheumatic carditis. To identify streptococci in throat by throat culture, then throat culture is inoculated. 1/3 patient has no preceding history of pharyngitis, does not differentiate between carrier and active infection. Sensitivity, then coming to the rapid antigen, sensitivity is 95%, specificity is 60 to 90%. Positive predictive value is high. If it is positive, then it indicates infection, but negative should be confirmed by the other test. Then the anti-streptococcal antibodies, extracellular is streptolysin O, that is ASO, DNS, anti-DNS B, anti-hyaluronidase, streptokinase, anti-streptokinase, etc. These are the group specific cell wall associated protein. NTM protein can be there. I will not go in details. Epidemiological factor influencing antibody levels are the age, geographical location, socio-economic status, season of the year, and genetic factor. Coming to the antibody titer, onset of clinical feature of rheumatic fever coincide with the peak of streptococcal antibody response. Antibodies to extracellular streptococcal antigen rises during first month after infection and plateaus for 3 to 6 months before declining. Normal level comes within 6 to 12 months. Significant increase in titer, rise in titer of 2 or more dilution increment between acute and convalescent phase. Various ASO we know more than 240 Todd units in adults and more than 320 in children above the age of 4 years. ASO response also affected by severity of infection. High ASO indicates severe arthritis or carditis. Appears in 7 to 10 days, highest in 2 to 3 weeks, and usually comes down after 12 months. Then anti-deoxyribonuclease, it is also a higher titer in skin infection than ASO. Then anti-hyaluronidase, fewer false positive tests. Anti-hyaluronidase in all patients with rheumatic compared with ASO only. Useful in diagnosis of rheumatic fever of latent onset, and it can be used for monitoring the therapy. So combining various serological tests, if you use ASO alone, then the 80% sensitivity. If you use anti-DNS, 82%, but if you use together, it is 99% ASO plus anti-DNS. Exceptions to Jones criteria, as I already said, chorea, insidious onset carditis, and recurrence of rheumatic fever. So, coming to the recurrence of rheumatic fever, history of rheumatic fever or ISD increase the risk of recurrent rheumatic fever. New onset of rheumatic fever in patient with previous history of rheumatic fever. Most patients will fulfill criteria, however, in some less apparent. Difficult to establish carditis in someone who already had rheumatic heart disease. Presumptive diagnosis of rheumatic fever is single major or several minor criteria in presence of reliable history of rheumatic fever or established RSD provided supported by gas infection. Carditis, usually there is a pericardial friction or change in the pre-existing murmur, change in cardiac silhouette, CCF, endomyocardial biopsy, new onset CHF as the only evidence of carditis in patients with established rheumatic heart disease. The mimetic feature of rheumatic fever, recurrence of rheumatic fever often have some clinical patterns as previous attack. Arthritis or chorea can also occur in patients with carditis. Non-cardiac manifestation may occur when they are present during first attack. So susceptibility factors is the state of the host, age, already said younger age, size of the tonsils, bigger the tonsils, more chances, number of previous episode, increase in the risk with each episode, presence of heart disease, oral prophylaxis rather than injectable prophylaxis, because injectable prophylaxis is more effective. So importance of echo subclinical carditis in some high risk, example chorea or post streptococcal reactive arthritis. You can diagnose the subclinical carditis by echo to eliminate false positive diagnosis prior to stoppage of antibiotic prophylaxis in patient with rheumatic fever without carditis. Coming to the echocardiac characteristic of ARF, the pathological length more than 1 centimeter beyond the wall that is the regurgitant end. If it is less than 1 centimeter, it can be physiological. Duration throughout the phase of the cardiac cycle, at least and seen in two planes. So various echocardiographic features are the M mode. You see the dimension of LA, aorta and their ratio, left ventricle dimension which can be enlarged. Then coming to the cross section, thickness of the walls with less than 3 millimeters taken as normal, more than 4 millimeters as thickened, beaded appearance, prolapse of the mitral valve, particularly the aortic leaflet also, aortic leaflet, decrease or increased mobility of the valves, hyper echogenicity and thickened submitral apparatus, caudal tear to mitral leaflets, pericardial effusion, endocardial diastolic volume, then by color Doppler establishment of MR, AR and TR, differentiation of physiological and pathological regurgitation. The incidence of various echocardiographic features, if you see thickness is the most important, then the regurgitation, mitral valve prolapse, rheumatic nodules, these all decrease in the sensitive percentage as you go down. Then the pathological MR and pathological AR definition seen in two views, both should be seen in two views. In at least one view, jet lag should be more than 2 cm per MR and 1 cm per AR. Peak velocity more than 3 meter per second for both. Pen systolic jet in at least one envelope, pen diastolic jet in at least one envelope for AR. So morphological findings of echocardiogram in rheumatic valvulitis, I already discussed. Acute mitral valve changes, annular dilatation, caudal elongation, caudal rupture, beaded appearance. Then in the chronic mitral regurgitation, there is a leaflet thickening, caudal thickening and fusion, restrictive leaflet motion and calcification which causes mitral stenosis. Aortic valve changes in either acute or chronic carditis. There is irregular or focal leaflet thickening, cooptation defect, restricted leaflet motion and leaflet prolapse. So if you see the clinical and echo, there is a difference, especially echo you are able to diagnose more cases as compared to clinical judgment, especially in present day scenario. So there is evolving role of echocardiography in the diagnosis of the rheumatic heart disease, which was included in India also by Indian working group in 2008 that echo should be used to diagnose the rheumatic fever. New Zealand also, the guidelines also recommended, WHO also recommends it. So role of endomyocardial biopsy, S-CHOP nodules or histiocyte aggregate, a diagnostic feature of rheumatic carditis seen in biopsy specimen, does not provide additional diagnosis information. Role of troponin in acute rheumatic fever, no difference in troponin levels in patient with carditis or without carditis. It is indicated that true myocarditis is not present, rather it is a manifestation of valvular insufficiency. Radionuclide imaging, insufficient data to support the routine use. Then the differential diagnosis of rheumatic fever may be SLE, rheumatoid arthritis and the Lyme's disease. this is the cycle. If you see the chorea, then the clinical just it is present, then you have to see for the acute rheumatic fever. If it is echo Doppler, there is subclinical carditis, then acute rheumatic fever is diagnosed. If clinical carditis, again echo confirms and associated there is one minor criteria, then the probable acute rheumatic fever, repeat echo at 14 to 20 days. If echo is negative, alternate diagnosis should be think another. If there are another major criteria and two minor criteria present, then acute rheumatic fever is diagnosed. Arthritis, again you see for no carditis, two minor or another major is present, then ARF is diagnosed. If there is no criteria, then alternative diagnosis should be sought. So differential diagnosis, if you coming to the polyarthritis, there can be septic arthritis, viral arthropathy, reactive arthropathy, Lyme's disease, sickle cell anemia, infective endocarditis, leukemia. If you see the carditis, it is innocent murmur, mitral valve prolapse, congenital heart disease, infective endocarditis, HOCM, etc. Chorea, differential diagnosis, systemic lupus erythematosus, drug intoxication, Wilson's disease, tic disorder, chorioarthritis, cerebral palsy. So coming to the investigation, WBC count which is red, ESR which is red, CA reactive protein, blood cultures if febrile, ECG for seeing the prolonged PR interval, chest X-ray for to see the cardiomegaly, echo as already did, throat culture and various serology. Test for alternate diagnosis like repeat blood culture, joint aspirate, copper, cerebrospinal, etc. levels. So management, coming to the management, the immediate is the eradication of Streptococcus from the throat to suppress inflammatory response, and management of acute complications and to provide symptomatic relief. And the long term management is the prevention of recurrence, secondary prophylaxis and treatment of chronic rheumatic heart disease. So if you use there are various regimes used for the given aspirin is given for 100 mg per kg for 2 to 3 weeks in the regime 1, and then tapered slowly over the next couple of weeks. And if patient does not respond to aspirin, then you can use the steroids and even naproxen has also been to 10 to 12 mg per kg in some patients. Then the steroid prednisolone 2 mg per kg usually given for 2 weeks and taper over the next 2 to 4 weeks, and you can overlap the steroid with the aspirin in the after 2 to 3 weeks. And usually the steroid is used in severe cases of carditis. If it's the carditis, mild carditis or no carditis, you can aspirin is enough. Other drugs which are used in the management like the digoxin, diuretics, ACE inhibitors, sodium nitroprusside for in the patient with the heart failure, inotropes like dobutamine, milrinone, etc. And surgery, severe mitral regurgitation due to cord rupture leading to refractory CHF. Coming to the eradication of Streptococcus, prevention of rheumatic fever, benzathine penicillin is 6 lakhs units for below 27 and 12 lakhs unit more than 27 kg weight. I am only once. If you don't use, then the penicillin V 250 mg BD for children for 10 days, and adolescent and adult 500 mg BD for 10 days. And for secondary prophylaxis, benzathine penicillin 12 lakhs units every 3 to 4 weeks, or penicillin V, that is the 250 mg PID for every day. So usually sulfonamide, trimethoprim, tetracycline is not recommended. So management of the complication, if there is no carditis, bed rest of 2 weeks is enough. If there is uncomplicated carditis, bed rest of 4 weeks. If carditis with cardiomegaly, it is usually for 6 to 8 weeks. If carditis with CHF, you have to give bed rest for 12 weeks. It should be followed by gradual ambulation for a period not less than period of strict bed rest. So no carditis, bed rest for 2 weeks. Carditis, as I already discussed this. Then coming to the eradication of Streptococcus, oral penicillin usually given for 7 days or 3-day regime. There are two regimes. Streptococcal eradication is 72% for and 41% with this regime. Recurrence is more common in 3-day group, so 7-day group is better. Other things which can be azithromycin 500 mg for the first day and then 250 mg 4 days. Cephalosporin, cefotroxil, cephalexin for 5 days, comparable to 10-day penicillin, but not yet approved by the US FDA. Throat cultures in follow-up usually 2 to 7 days after treatment. In symptomatic, if the patient are still symptomatic, recurrent symptoms, he had rheumatic fever in the past. Penicillin failure, again, you can use amoxicillin, clavulanate, cephalosporin, clindamycin, or penicillin plus rifampicin. Anti-inflammatory drug aspirin and corticosteroids, as already said, both of these does not affect the course of the carditis, do not reduce the incidence of residual heart disease as well, but only gives the symptomatic relief. For mild carditis, aspirin 100 mg per day in 4 to 5 6 divided doses for 2 weeks, and maintain aspirin level for 2 to 20 mg, taper over the next 6 weeks. Prednisolone 2 mg per day for 2 to 3 weeks, taper for 5 mg every day for 2 to 3 days over 2 to 3 weeks. When tapering for or 1 week prior to withdrawal, add aspirin 75 mg per kg per day for 6 weeks after steroids are stopped. Relapse worsening with treatment or can be seen in 2 to 4% of patients with salicylate, rare after with the use of steroids, and if there is relapse, then use the steroids instead of salicylates. Rebound reappearance of symptoms during tapering, more with the corticosteroid, add salicylate. CRP is negative, ESR starts elevating. While on treatment, ASO should not be the guide to treatment, rather ESR and CRP should be followed up. Role of steroid, US and UK joint report 1962 that there is no superiority of corticosteroids over salicylate for residual cardiac damage. So cardiac damage, the course of the disease is not changed. Combined, no superiority of corticosteroid at the end of 1 year. So role of IV immunoglobulin, no benefit in disease course, progression or development of chronic rheumatic heart disease. CHF, you can use arterial vasodilators for severe MR, like digoxin diuretics. Patient who are hypersensitive to digoxin, should not be used. Then the valve replacement, intractable hemodynamic deterioration requires valve replacement and reasonably good results. Arthritis, as already said, salicylates is used. Then you can use naproxen in case some patients which are not responding to salicylate. Equally effective in decreasing the symptoms and lab parameters with significant absence of side effects, especially hepatic enzyme elevation, which is associated with the salicylate. Tolmetin again versus aspirin, some same results as with the naproxen. Chorea, you require bed rest, sedative, avoid stress, haloperidol, valproate, and steroids rarely. So coming to the secondary prophylaxis, penicillin resistance not known yet. Resistance to clindamycin, tetracycline, sulfonamides have been reported. So still the penicillin is the gold standard. IM penicillin is more effective than oral penicillin for prophylaxis. 4 weekly regime, that is streptococcal infection rate and recurrence is higher with the 4 weekly regime. So 2 weekly better than 4 weekly regime in decreasing rheumatic fever recurrences. And 3 weekly, if you see the 3 weekly versus 4 weekly, hypothesis, the level of penicillin depends on the protein binding. Level of penicillin becomes inadequate after 3 weeks in majority of cases. So level fell below MIC at the 18th day. So in children it is 14 day infection reported. Juvenile patient pilot is 3 weekly versus 2 weekly, no difference. So penicillin secondary prophylaxis 12-year prospective study 5 times higher prophylactic failure in 4 weekly versus 3 weekly group. So 3 weekly group is better. So fear of penicillin is always there, although it is not that common. It can occur immediate, accelerated, or late after 72 hours. 3.2% cases of allergic reactions has been reported. 1.23% anaphylaxis per 10,000 injections, and 0.31 death per 10,000 in general population. So you require proper skin testing and the reassurance, and especially cautious in 12 years age with advanced rheumatic heart disease. So what duration of the prophylaxis? Patient with proven carditis for 5 years after last attack or until 18 years, whichever is longer. Patient with carditis, mild MR, healed carditis for 10 years after last attack or at least 25 years of age, whichever is longer. Severe valvular disease requires lifelong treatment. After surgery, it is again lifelong treatment. So the measures that may reduce the pain of injection, because very painful injection, and many general practitioners and private doctors are afraid of giving it because of the allergic reaction. Use the warm syringe in room temperature. Allow alcohol for swab to dry before inserting needle. Apply pressure with thumb for 10 seconds. Deliver injection very slowly over 2 to 3 minutes. Distract patient during injection. And then coming to the vaccines, which can be against various antigen, especially M protein. The vaccine is still, because it is so, M protein is variable in different strains, so it is still under trial, and it is not a very well developed vaccine, is still not available. So conclusion, rheumatic heart disease is still a major cause of morbidity in developing countries. Pathogenesis diagnostic modalities are changing. Still, Jones criteria remain cornerstone for diagnostic purpose. Genetic research should be focused on understand the predominant valvular strains in our population and whether gas mutants are evolving high prevalence area, so that vaccine against that can be targeted. Pending three research, these research need of the hour is to better implement of the, very important is the primary and secondary prophylaxis of rheumatic fever and timely management of the complications. Thank you.